Good morning, good afternoon, good evening. Welcome to the 11th South-South Forum on Sustainability. This year, the main theme is Health and the Road to Sustainability. May I introduce myself first? My name is Tsui, Jade Margaret. I am Associate Professor of the Institute of Rural Reconstruction of China at Southwest University. And I'm also the founding member of Global University for Sustainability. The first speaker is Professor JOMO Sundaram. He is a senior advisor, Khazanah Research Institute, Fellow of Academy of Science, Malaysia, and Emeritus Professor, University of Malaya. He was UN Assistant Secretary General for Economic Development, Assistant Director General, Food and Agriculture Organization, Founder Chair, International Development Economics Associates, and President of Malaysian Social Science Association. JOMO has authored and edited over 100 books, written many academic papers, research reports, and media articles. Besides translating 12 volumes, he received the 2007 Leontief Prize for advancing the frontiers of economic thought. And the second speaker is Professor Tiejun. He is professor at the Institute of Advanced Studies for Sustainability, Renmin University of China, and former executive dean of the School of Agriculture Economics and Rural Development at Renmin University of China. He is also executive dean of the Institute of Rural Reconstruction of the Rice, Fujian Agriculture and Forestry University, and distinguished professor, Haikou University of Economics. He is a leading scholar on macroeconomics and rural issues and an independent non-executive director of the Postal Savings Bank of China. His monograph, 10 Crises, The Political Economy of China Development from 1949 to 2020 can be downloaded for free on the websites of the Global U and Paragraph Macmillan. And we also have two more speakers. However, due to some unavoidable reasons, they may try their best to join us. And the third speaker is Hernan Vargas. He is Minister for Communal Economy of the Communes and Social Movement Ministry of the Bolivarian Republic of Venezuela. Now he is in the eastern region of Venezuela because of the hurricanes in the Caribbean. So he is now trapped in the airport and is confronting with the chaos. So he will try his best to join us. And the fourth speaker is Dr. Mira Shira. She is director for the Initiative for Health, Equality, and Society, an advisory council member, People's Health Movement from India. Unfortunately, due to unavoidable reasons, she cannot be able to join. She sent her her apologies to the colleagues and organizers. So let us start our sections. So I would like to invite Professor JOMO. Thank you.
Thank you very much, Jade, and thank you for putting me on this panel with Professor Wen, who I greatly respect. And to our American friends, I think it is appropriate to celebrate the 4th of July, which is the day of Declaration of Independence of the United States. And in many ways, the United States Declaration of Independence from the United Kingdom anticipated many of the struggles for national liberation all over the world. In fact, Vietnam, Ho Chi Minh basically incorporated some of the sentences from the Declaration of Independence when Vietnam declared independence itself. So allow me now to turn to my PowerPoint, and I hope you can see my PowerPoint. I'm sorry I cannot use the full screen function, but I hope this is enough. Are you able to see the PowerPoint?
Yes.
Okay, very good. Now, I think that I'm basically presenting two different making two different presentations. One is a major challenge faced by many developing countries, which is how do we have sustainable healthcare financing? The WHO has a slogan of health for all, which almost all countries in the world have signed up to. And the Sustainable Development Goal, one of them is for universal healthcare. But how do we achieve this through to make sure that there is sufficient financing? And I will be discussing some problems associated with that. And then the second presentation I'm going to make, which is basically on how to improve nutrition. We have paid a lot of attention to food security issues, but I think it is also very important for us to pay much more attention to questions of improving nutrition. So let me move to the. I think everybody knows the problems of the U.S. Healthcare system. Even though I think many people do not realize that a lot of there are some socially government finance things like Medicare and so on, which makes the situation not as bad as it would be otherwise. But basically, we have the US and a few other economies in the world having what is private or voluntary health insurance. And this, of course, basically means that only those who can afford it participate. And so the insurance risk pooling, what the insurance people call risk pooling, is only for those who can afford it, for the people who are relatively wealthy. And it's also important to recognize that as a result of that, there is a whole bureaucracy associated with insurance management. And there is also, as a consequence, insurance companies do have a lot of problems, including what is called moral hazard and cherry picking, which allows them to maximize their profits, because that's what they are in the business for. Not to take care of, to improve the health or well-being, but rather to make as much money as possible from the health insurance system. Now, the people like us who basically pay for healthcare in the United States because they participate in insurance as individuals, they do not have much negotiating power with the healthcare providers or with the insurance companies. And as a result of this, we find that the cost of healthcare in the United States has actually been going up faster than in most other economies of the world for a variety of reasons. Most importantly, the higher cost of medicines and therapies because of the nature of the US system. Now, let me quickly turn to another alternative, which is quite popular in very few countries actually in the West. It is mainly the system which has been inherited in Germany and a few other European countries, which is called social health insurance. Sometimes it is used, other names are used. And what we find is that as a result, social health insurance has a huge range of problems, which I will go into in a minute. But I think it is important to contrast that with government finance healthcare, with government healthcare financing, where you have much more risk pooling for a large population, the national populations. It is much more efficient and cost effective. Many people don't realize this because you eliminate the whole bureaucracy of insurance. It is less expensive and also more sustainable for the same reason. Now, let me quickly show you this graph. And what you see from this bar chart is that the spending per capita is highest in the world in the US. And the main reason is because of health insurance administration. And because it is so dysfunctional, the US spends a lot of money on healthcare, but they do not have very good outcomes. They are number one in terms of spending, but as a result of, despite spending so much on healthcare, they are only number 40 in terms of life expectancy in the world. So we have a lot of problems, which I won't get into right now because of time constraints, but I think it is important to recognize that social health insurance is also not sustainable in the long run for a variety of reasons. So you have upward pressures on costs also because of the use of insurance mechanisms. There are various problems which economists call moral hazards, which I referred to earlier as well. And you have provider-induced demand. So, for example, you have a problem where the healthcare provider, including doctors and specialists, they basically will recommend certain procedures, not because they are needed, but because these procedures, through recommending those procedures, they will get some income. So you basically introduce a lot of perverse incentives with social health insurance. And then you have, as a result of various other problems, including the private nature of pharmaceutical spending, of pharmaceutical provision, medicines, the cost goes up. So this is very important for us to remember, because many people think that social health insurance is better than a private or voluntary health insurance. It is better in some ways, but it is still suboptimal. And that's the point I'm trying to make, that because you're paying so much for insurance mechanisms, it causes a lot of problems. One of the other consequences is that where you have social health insurance, in many countries where they have social health insurance, the employers try to avoid making contributions. And what do? They do not directly employ workers. Instead, they employ workers indirectly through various types of contractual agreements to avoid paying their contribution to social health insurance. So the entire cost of the insurance is borne by the population. And this, as a result of this, so you have, as a result of this, the labor force is much more involved in what are called informal labor relations, less formal employment, and there is a smaller base for collecting the revenue, and also smaller base for collecting social health insurance. And this, in some economies, I'm not saying this. This was shown by a former World Bank economist named Adam Wagstaff, who passed away, that there is, as a result of this, increased unemployment in the OECD countries, decreased contributions, and decreased coverage. So all this is basically important, because many people think that social and health insurance is better, especially people who are trained in the US. Because when they are trained in the US, they know that private health insurance and voluntary health insurance is a problem, and they think the better alternative is social health insurance. And but we have to recognize that the social health insurance is increasingly unsustainable because of the factors, including what is called a demographic transition, where people are getting older, and as a consequence of getting older, the health costs in society are rising, and this is inevitable when people get older. And it's also important to recognize that in societies such as Germany, where you have social health insurance, what you also have as a consequence is much more government spending to compensate for the increasing gaps left by the social health insurance system. So, for example, going back to another comparative chart, you will find that the health spending per capita in the world, number one is the US, almost 10,000 per capita per annum, and then Germany is number two. The reason Germany is number two, I know it's difficult for you to see this bar chart, but Germany is number two precisely because of the additional cost of health insurance and managing health insurance. Because when you have an insurance system, a real insurance system, okay, you find that many people are trying to try to abuse the system, not only healthcare providers, but some others as well. And as a result of this, you have the insurance companies to make as much make as much as possible. They try to ensure that kind of cheating does not happen. And when they do that, what happens as a consequence is that you have a situation where you have a bureaucracy just for insurance, got nothing to do with providing healthcare, just for insurance, for managing insurance. So this is very important to recognize, because people often think that it is cheaper, but in fact, it is not cheaper. And it's also important to remember that in some societies, for example, in Canada or in the UK, they talk about national insurance, but in fact, national insurance is not insurance as a system which actuaries and others know. Rather, the system is really one of it is really based on taxation, which the population pays, rather than an insurance mechanism. And so you can change the incentives. I'll come back to this later. So the social health insurance claims to address two problems, which I would say are not true. Number one, it claims to raise more money, which is not true. And secondly, it claims to integrate the public healthcare with private sector. And obviously, you need to change incentives, but in a tax finance system. But basically, I'm going to argue that these are both not honest claims. You do not raise more money through social health insurance. In fact, you have less money for healthcare. You might raise more money for the insurance mechanism, but as I told you, most of the expenditure on the insurance system is wasted on insurance. On the insurance system, it is not used for healthcare, and this is important to recognize. So this is an article from this data is really taken from the World Bank, and the World Bank. Yeah, there's this man named Adam Wagstaff who had unfortunately passed away some years ago. He basically said, you spend much more money. That per capita spending on health goes up by about 3 to 4% without corresponding improvements in health outcomes, simply because you're using an insurance mechanism. And you also have worse mortality rates for certain types of morbidity conditions, such as, for example, breast cancer, because there is no incentive. Because the whole emphasis is on therapeutic or curative medicine, there is no incentive to, for example, do much more on public health and so on. This is the bias which is introduced by the health insurance system. So, and you find that in most societies, people resist health insurance, because for them, they just see it as another form of taxation. They are trying to avoid not just the employers, even ordinary people, self-employed people, and this becomes a huge problem. So you have much more fairer society and greater access to healthcare, especially when you have a tax finance system. Now, the next point I want to make is that when you have a revenue or tax finance system of health financing, it is much more egalitarian. It is also contributes to nation building, because everybody feels that they're part of the nation. The nation provides, and they feel part of this nation. And it also helps a lot to move towards various globally recognized or internationally recognized norms, which I referred to earlier. Okay, so the next point I think, which is important to make, is that the challenges for government provided healthcare is that we find that especially when you have a private system coexisting with the government system, that some people who are basically out to make money may choose to go to the private system, or they might choose to go abroad and so on. And let us not deny that there are such cases as well. And you also, therefore, find that people, many of the most experienced staff may go to the private sector to become specialists in the private sector where they can earn much more and so on. So it is very important to recognize this and to provide incentives to ensure that people who are working in the government healthcare system are sufficiently remunerated. You can't treat them badly and expect them and treat them just like any other public servants. And it's very important also to recognize that, you know, the care services in our societies, the so-called care economy, is generally underfinanced. So by financing health, you're also addressing the lack of financing for the care economy. So the next point, I think, which I would like to make here, is to recognize that there have been very uneven improvements in health indicators, and there is a lot of campaigning by private health insurance lobbies in all our societies. In my country, which is a developing country, upper middle income country, we find this, but it is in many societies, because the whole insurance system will collapse once you have a serious commitment to government provided healthcare. So the next point, I think I'll just make very quickly, is that the norms, the international norms which I referred to earlier, of providing universal healthcare more equitably and so on, and sustainably. This is very important, and to promote social solidarity and provide a certain degree of cross-subsidization. You will find that this is all very much achieved through government-provided healthcare rather than through insurance systems. So healthcare system reforms are very important, and I think it is important for us to recognize that you know, healthcare reforms are essentially things which need to be addressed much more systematically. But there's no one answer about how to ensure what are the best healthcare system reforms which are needed. The financing part is very, very important, but it is also important to recognize that in many societies there are specific challenges. I mentioned one earlier, which in my society and in many other neighboring countries is a problem. People don't want to stay in government service because conditions are not well, and you often have bureaucrats who are making policy rather than the professionals. And all this is important for us to recognize. So just solving the financing problem doesn't mean that all the problems of improving healthcare are solved. The next point I want to make is just to remind you that my own society, we made a lot of progress before. During the 1960s and 1970s. But from the 1980s, with a lot of pressure, with a lot of emphasis on privatization and so on, we have seen some progress, but it has been less progress. And we have had a big problem of increase of what are called non-communicable diseases. Which are problems which many societies, as they become better off, lifestyles change, and you have a new range of problems. In some societies, for example, you have problems relating to smoking. In other societies, too much sugar consumption, and so on and so forth. And these are often related to a whole range of other health issues and so on. So I don't want to belabor the point about Malaysia, but I think it's important to recognize that there are problems in all our societies which need to be addressed, and that the whole question of financing is part of a larger challenge. So it's also important to recognize that now there are new ways of looking at many of these issues. So and one of the popular measures are what are called dailies, disability adjusted life years lost, and this is important to recognize, because the usual measure of focusing on life expectancy is just not good enough. Now, in Asia Pacific countries, because I suspect that most of the people who are watching at this hour are from this part of the world, you can see that there has been progress, but very, very relatively modest progress, especially among men. Female life expectancy is actually much better throughout the East Asian region, and there are many reasons for this, which I won't get into right now. But in my country, for example, the gap between male and female life expectancy is between 4 to 5 years on average. And so one has to think about the challenges for providing for healthcare for older women, who often find themselves living on their own. And especially as society is becoming more atomized, and there is less family support and so on. So we have to also recognize that primary healthcare spendings have generally lagged behind what are called secondary and tertiary healthcare spending. And we have to make sure there are enough allocations to primary healthcare. Now, this is almost impossible for most people to see and read, but it basically implies that there are many deaths which are avoidable if you have a better health system. I won't get into it right now because you can't read it on the screen, but I think it's also important to recognize that very often we find that the healthcare systems, especially when they are not on the basis of government's spending, and you do not have enough emphasis on public health, many non-communicable diseases are undiagnosed. In this country, for example, it is estimated that half are undiagnosed. In other countries, it is probably, other developing countries, it's probably higher. And so, for example, almost the entire population has at least one NCD risk factor. And these are real problems which unfortunately do not get sufficiently addressed. And of course, we need to recognize that at different stages of life cycle, there are different health needs, and we also need to recognize, for example, the different health needs of women compared to men. One of the major problems, for example, which has been highlighted in Malaysia only in recent years, is that many poor women cannot afford to deal with the menses, and they use old rags and so on to deal with the menses, and this introduces all kinds of infections which are very dangerous, some of which are very dangerous, and even some people suggest the possibility of cervical cancers. Now, let me stop here in case there are any problems of clarification which need to be made. Okay, now I think it's important for us to recognize that we, in some parts of the world, especially in the so-called middle-income countries, we do not have very serious food insecurity. Of course, it depends on the levels of inequality and the levels of food supplies and so on. But what we find is that there has been very little attention paid to malnutrition at the global level. And I want to address this problem briefly in this presentation. But I just want to say one more thing about food security. If you look at the official figures coming out from the Food and Agriculture Organization. Food and Agriculture Organization estimates that food insecurity, people who do not get enough food, are actually the majority, have actually been going up much more than poverty. And part of the reason is that food prices are going up much more compared to incomes. So incomes have been going up, but food prices have also been going up much more, and as a result, many people do not get food. Another reason, of course, is that many people no longer live in the countryside. The population of the world is more than half urban now, and the result is that even if they wanted to, they cannot grow their own food because they live in urban areas. And so the possibility of increasing food provision in urban areas is an issue which has been coming up recently. But here I want to focus on the major challenge of malnutrition. First, we have the problem of what are called macronutrients. Okay, if you don't have enough carbohydrates, calories, or if you don't get enough protein, those are considered problems of macronutrients, and both, of course, are very important and so on. But and usually when you talk about measurement of poverty, of food insecurity, most of the time what is being referred to is just whether you're getting enough calories. In other words, whether people are able to do physical work. The official definition in which the FAO uses is basically whether you have enough to do physical work. And this is a very, very low and minimalist definition, okay, which was agreed to in the 1960s when there was relatively little knowledge of these challenges. So now, although it has been more than half a century since then, nobody pays attention to thinking about all the other macronutrients, including protein requirements. So you have, as a result of that, a lot of children in the world who do not get enough protein at an early age, and the result is what is called stunting and related problems. The second issue are what are called micronutrients. And here I'm referring mainly to what are called minerals, vitamins, and for some people also trace elements. Trace elements are a bit like minerals, but they are important for our life. And I don't want to get into a technical discussion on nutrition here. I'm not very qualified in this area, but I think it's important to recognize that micronutrients are also very important, maybe very small quantities. For example, if you do not have enough iodine, you have a problem. And so these kinds of micronutrient deficiencies are often referred to as hidden hunger. And then the third problem are basically non-communicable diseases. Now, the West is mainly concerned about obesity, and that undoubtedly is a very major problem. And we often think that it is the rich countries which suffer from obesity and overweightness. In fact, that is no longer true. It is middle-income countries which are now the worst. At the beginning of this century, Mexico overtook the US. The US was number one during the late 20th century, by far. But Mexico overtook the US in the year 2000. And coincidentally, I'm not saying causation, but coincidentally, the president of Coca-Cola in Mexico became the president of Mexico in that year. Okay, so it's a coincidence. I'm not saying that one caused the other, but you will, for those who are in North America, you will know that Mexican Coca-Cola is not easily available in the US. Now, but I think for many of us, we have to think about the other non-communicable diseases in our societies. And I won't go through a list of them, but there are many of them which are related to food and diets. Okay, so do keep that in mind. So just to give you some summary figures, these are some of them are very old figures. The situation, unfortunately, has not gotten better. In some cases, it has gotten worse. But about a decade ago, this was the number of this was some of the data. As I said, the numbers have changed since then. So you find, just to focus on micronutrient deficiencies, you have hidden hunger at the global level, which are very, very serious. And you can see that the countries which suffer the most are basically countries in Asia and in sub-Saharan Africa, but also some countries in Latin America. Now, but you know, this map doesn't give you a very clear idea, because every country has its own specific issues, and the question of whether you have enough food is not directly related to the question of whether you have a balanced diet and whether you have problems of micronutrient deficiencies. Now, this is an estimate by the West, okay? And I would say that I don't like this kind of estimates, and I'll tell you why. The main reason why I don't like these estimates are that basically it gives so-called economic value to life and to good health, which is very, very difficult to measure, okay? So it is very arbitrary. So what they mean here by the economic cost of malnutrition being 5% of GDP, it means, for example, obese people and overweight people are not able to work efficiently, and therefore it costs about 5% of GDP, okay? But so the work of people in the West is valued much higher. So the result is that this figure of 5%. But what about people in poor countries? What about people in Africa who are suffering from malnutrition? They are given very low value, you know? I remember there was a chief economist of the World Bank. He later became president of Harvard University, Larry Summers. He basically said, oh, the value of life in Africa is lower, so you can dump toxic waste in Africa, because what the economists call opportunity cost of life is lower in Africa. I mean, this is the kind of cynical view which you have. And now, increasingly, you have a lot of dumping of toxic waste or getting rid of problems in many ways by dumping them into the commons or into in other countries. So there are many developing countries which are importing, for example, plastic waste. Or recently, the Japanese released the radioactive Fukushima water into the Pacific Ocean. So, you know, these are problems where rich countries feel they can do anything they like. They can abuse the global commons. And this is a problem, of course, relating to climate change as well, which I won't get into right now. But let me quickly just focus on obesity, because this is what the West focus on. And just on obesity alone, okay, the cost of obesity estimated by the McKinsey Global Institute. McKinsey is a consultancy company, and they find that about 30% of the world's population is at least overweight. And of that those people who are overweight, one third, that means 10% of the world's population are obese. Okay, 10% of the world's population are obese. And you find that the cost, according to McKinsey, is very high. Think about the cost of armed conflicts. Armed conflicts, at least when McKinsey was estimating this about a decade ago, cost about more than 2 trillion. They are number one. And smoking costs about 2 trillion. Okay, 2 trillion. Okay, and basically that is the cost of obesity as well, about 2 trillion. Okay, so we are talking about a very high economic burden, and remember that we have not looked at other consequences of malnutrition. Okay, but as I have already expressed my reservations about this way of measuring. Now, if you look at another way of looking at it, if you think about malnutrition burdens, 3 types of malnutrition. 1, obesity, I mentioned earlier. 2, child micronutrient deficiencies, only among children. and 3, child stunting. You will find that among the almost about 200 countries in the world, only 16 countries, 16 countries suffer from all 3 problems, but only about 15 countries in the world do not have these problems. Only 15 countries. That means most of the rich countries also face these problems, at least one of these problems. Okay? So we are talking about very, very few countries which are exempt. So when we talk about the sustainable development goals being for everybody, we are also talking about the rich countries. They need to pay attention to many of these issues. So let me now emphasize that, for example, in my own country, we have so-called double burden of malnutrition. Because we are so influenced by the West, we still are obsessed with the question of obesity, which I agree is important, but it's not the only problem for most developing countries, And then you have a range of other problems. So in Malaysia, for example, last year I went to see an old friend of mine who started the first anti-diabetes campaign. And I said to him, Khalid, you did a very good thing by starting this anti-diabetes campaign. And he said to me with great regret, that he failed. And the reason he said he failed completely. And I asked him why. He said when he started the campaign in the 1980s, at that time, the number of Malaysians with diabetes, mainly type 1 diabetes, was about 8%. Now, the figure is around 25%, more than 3 times. Okay? It's huge. It's a huge problem in the country, and unfortunately, very little attention is paid to it. One special problem which affects women and children is anemia. Okay? Anemia means lack of iron in the blood. So I remember I was involved in China when after the Beijing Olympics, President Hu gave one of the buildings to the International Poverty Center, and they asked what can be done, and I suggested, why don't you have a school feeding program? And later on in 2012, when I went back, I was told that the school feeding program had succeeded, and they wanted to thank me for it. But in fact, they did much better than what I was suggesting, because I said, why don't we give a school breakfast program? And they said, well, children will come to school, poor children will come to school, and then after breakfast they will go home to work. But with the school with a feeding program in midday, they will have some breakfast at home, mainly leftover from the rice from the previous day or something like that, and then they will come to school and they will eat something, and then they are basically required to stay in the school and eat. And then in these poor areas, they were also trying to address problems. So they introduced, for example, new vegetables like red spinach. Red spinach has got a higher iron content, and so anemia within that poor community went down. And basically, the quality of children also improved. So much so that after 4 years, between 2008 and 2012, according to the vice minister in charge of poverty, he was saying that basically the nutrition indicators of poor children in these poor areas was actually better than in Shanghai. Okay, so it gives you an idea that you can actually do a lot of interventions which will help relatively poor children, especially if you're directing and you focus on the problems of relatively poorer people and so on. So I think it's important for us to recognize that these are important challenges. So my last slide is that so when we think about food security, let me encourage everybody who is concerned about food security to think more broadly, to think about not only food security, but also the conditions under which food production is conducted, and also how food consumption, nutrition. So I want to emphasize the importance of production, because many countries, especially countries like mine, we are using a lot of toxic pesticides. So the vegetables, for example, they look nicer. Okay, there are very few insects, holes, and so on and so forth. But often, unless you have strict enforcement, the food is taken and sold in the market without making sure that the pesticides are no longer toxic. Okay, this is a very common problem throughout developing countries. And so many farmers now, they have 2 plots of land. They have in the larger farm, they are producing using all kinds of chemicals. And then they have a small plot for their own needs, because they know how dangerous these chemicals are. And they don't produce for the market in that way. So this is extremely important, because you might have very beautiful looking vegetables, but they are not safe. They're not safe for human consumption. So this is so we have to think about production, and at the level of production, we find that in developing countries, there are a lot of food losses. Okay, about 1/3 of what is produced is lost at the level of production. Another third is lost at the level of consumption, but that's a problem mainly of the rich countries, where they throw away a lot of food without consuming it. And of course, the rich in our own societies are also doing, are also responsible for a lot of food waste. But so we need to think about healthy and safe diets, okay? Safe in the sense of not having toxic substances and so on. So having a diversified, healthy diets is very important for all. And in many of our societies, this can be achieved through better production of vegetables and fruits. This is extremely important, because you can basically on a vegetable diet, you can get all what the body needs in terms of macro as well as micronutrients. We have to be very, very concerned with how with problems of antimicrobial resistance. We find that in many societies, we find that, for example, in fish breeding, a lot of antibiotics are being introduced into the fish ponds. And this results in what is now called antimicrobial resistance. Basically, antimicrobial resistance is basically resistance to antibiotics. So what basically means is that the fish survive, or whatever other animal you are breeding survives. But because we are consuming so much antibiotics, when we need antibiotics for our own health, we are not able to respond to it, because we are consuming so much antibiotics. And as you know, and generally you should not consume antibiotics except when you need it. So the result is that our own immune system is compromised due to excessive consumption of antibiotics through the food. And now one big problem which many people face, of course, is the plastics, which are now in the seawater and sometimes in fresh water. And plastics, we are consuming plastics. And recently there was a report about the level of plastic consumption. And incredibly, I was shocked to find that Malaysia has one of the highest plastic consumption. But almost all countries are now facing this problem, because the plastics are going into the sea. And this is a very major problem. So the other problem, of course, is that poor food providers reuse a lot of the cooking oil, and this results in trans fats. And also many people use preservatives, and all these have health implications which we need to pay attention to. My own recommendation continues to be, and we have seen very good results, not only in the Chinese poverty programs I mentioned earlier, but also in Brazil and many other countries. Fome Zero in Brazil was very important in ensuring that children have much better food, and so on and so forth. So we have a range of achievements which are often not known, which have been achieved in developing countries. And my last plea, of course, is to emphasize, to do much, much more through very simple interventions. Many in Malaysia, for example, the main reason life expectancy increased, more than 80% of the improvement in life expectancy was because of the reduction of maternal and infant mortality due to having midwives in all the villages. This was a simple introduction. And this was very important in improving, in reducing infant and maternal mortality. But the other very important thing which we should now think about is how these midwives can also advise expectant mothers and mothers after the birth of the child on feeding, on providing nutritional advice. And this is, I think, very important to ensure that the recommendations are culturally appropriate, because our food cultures are quite different in many parts of the world. And especially in the first 1,000 days from conception to around the age of 2, what the child receives at that time will basically shape their life chances in very, very important ways. So allow me to just stop here and thank you all for your attention. I think I'm sorry I took a little bit longer than than originally envisaged, but I hope this has been useful to you. Thank you.
Thank you very much, Professor JOMO. Thank you very much. And I would like to invite Professor Wen to do his presentation, please.
It's a great honor for me and also very delighted for me to discuss this problem. I think Professor JOMO has provided many data, statistics, and also the situation of different countries, and which is very helpful for us, for the whole world. And now, the whole world has already been shaken. The impact of COVID-19 pandemic, and also talking about the sustainable development and also the food and development of the society. And it is very important for the future development. And I would like to extend my sincere gratitude to Professor JOMO. I will not use the same way for my presentation. Sorry, I did not open my microphone. I would like to extend my gratitude to Professor JOMO, because Professor JOMO has provided different documents and statistics and also the research from different countries. And it is very important for us to discuss this new problem, which is the health and sustainable development, and also health and community. And as we just avoid the impacts of COVID-19 pandemic, and I hope that we can continue our discussion after this meeting. And today I would like to talk about some of my real-world experience through telling stories. And today our topic is the eco-community and also the health sustainability, which is I would like to repeat this topic, the eco-sustainability and also the health sustainability. First, I would like to start from the COVID-19 pandemic. And everyone have experienced this COVID-19 pandemic, and they have their own understanding about the pandemic. So during the pandemic, we can see one phenomena. There's places which is densely populated, mostly the cities. The pandemic have a very significant impact on the human's life. And many people died. And additionally, because of the isolation and quarantine, For example, by isolating different people in different buildings, some people are suffering from the mental problems, and also the whole society are facing big problems, the social problems. For example, the breakdown of the family ties, and also the negative impact of the relative bonds. So it has a very big negative impact on the society. But based on our research, on our understanding, the impact of pandemic in the villages, in the countryside, or those places such as the mountain areas with diversified eco conditions. For example, in the mountain areas, they have abundant water resources and also different other kind of resources. The COVID-19 pandemic, which took a great toll on the whole world, is not having such kind of significant impact in the mountain areas. So during the outbreak of the COVID-19 pandemic, I was in a village, and in the village, several young people were arranged to stop the outsiders to go into the villages. So within the villages, people can have a very normal life. So in the village, they do not need some medicines and also outside life equipment. And they can actually have a self-sustained, sustainable living conditions. As long as this kind of villages have abundant natural conditions, these villages seems like it will not suffer from the COVID-19 pandemic impact. But some kind of villages are impacted by the COVID-19 pandemic, which is the villages in the city, and i.e. the slums in other countries. And for example, the developed countries such as the United States, those heavily stricken areas by the COVID-19 pandemic are actually the places with many poor people. So based on our experience, when we talk about the health problem and also healthcare, we need to have the basic understanding that are impacted by the COVID-19 pandemic. We can see those less stricken areas is the villages and also mountain areas with the best eco conditions. So in the first day of this meeting, I mentioned that I had 2 videos which are transmitted across the society. The first video is that our best solutions comes from the eco-village. These villages have natural conditions and also abundant natural resources. So during this large pandemic, an important conditions for China to combat this COVID-19 pandemic is that China has a vast land, and also more than 70% of the land is mountain areas or deserts. And urban areas are mainly located in the plains. And the plains only accounted for 12% of the total land in China. So
it is because China, there are still many countrysides, eco-villages, that the natural environment there are really good, much better than the cities. That is why I would like to talk about like the eco-villages and the health sustainability. So I would like to share some stories with you. China still has a large majority of like the eco villages that are so close to nature, that are really connected to nature, which helps all these villages or villagers to be distant from the COVID, from the pandemic. And another phenomenon which would really help since the 90s and in the 90s, in the context of globalization, there are 300 million laborers, like migrant laborers. And most of them travel to, or most of them, they work in the city, but and they live in those like very dense communities in the city. Yeah, it's like yeah, there's no like trees, no parks, very dense. And most of the low income migrant workers, they live there within the city, but they are like the houses are very close to each other. Because like after the pandemic, a lot of the economic activity stopped in the city. So most of the migrant laborers, most of them, they return home to the villages, to the village. The village I was in, there was a very small like village. They only have like a dozen like households. There's a few like after those migrant workers returned back to hometown, because the nature or the environment still exists in the village. It's not like in the city, all the communities, they are like high-rise buildings. Yeah. In contrast, the village in the countryside is still like surrounded by mountains, by rivers. Yeah. All the buildings are maybe just a few storage, not like the high-rise building. They still like live spread out. And all these places, they didn't have to wear masks. They didn't have to take medicine. They just live as normal. The only thing they needed to do is to stop like the road. They stop the road with like dirt, or they just cut through the road so that people from outside couldn't enter their villages. Yeah, they only receive the local villagers. Yeah, it is really because the existence of villages, we can like prevent the pandemic with minimum cost, and also cut through the spread out or the pandemic of COVID. And the second video I made is to answer some of the audience questions. Like, for example, I was talking about those very dense dense community in city. How come they also have pandemic? Well, my answer is that they are no longer village, because it is no longer connected to nature. They are just like maybe in between rural area and urban area. And yeah, and this kind of area are affected mostly by COVID. And that's why I would like to, raise the importance of eco-village or ecological villages. They still have like nature and good natural environments around them. And I would propose that the sustainable health is only possible in eco-villages. Like 20 years ago, we had like SARS, like it's another kind of a pandemic. And it's like 20 years ago. SARS didn't happen just in mainland China, but also in Hong Kong. The denser the area it is more difficult to prevent SARS. And that was in 2003, like almost 21 years old. There's no like medicines available in rural area. But in such condition, the leaders of China, the chairman of leaders, he was very afraid, what if SARS enter into village? Yeah, it's the same like between now and between 20 years ago. The different villages, they just cut through the road that enter in the village. 2003, we were in like a village in Hebei province. A Congolese friend was with us in that village. He witnessed how rural area cuts through like the connection with cities, which turned out to be the best way to prevent SARS to affect that villages. Yeah, this is another. Yeah, SARS only existed in city, only happens in those areas that are very dense, very populated. So we can see, yes, on one hand, the health sustainability is related, or very large is related to like healthcare financing, all these mechanisms. But on the other hand, we also need to consider in the last like thousands years old, especially in this Chinese history, 5,000 years old, at least 5,000 years. Yeah, but like a lot of the historians has discovered like even longer histories. We've affected by different kind of pandemic. Why we can still be sustainable? One of the very important reason is that all these villages or like rural areas, they are tightly connected with natural resources or with nature. It's because the diversity of nature keep the diversity of cultures in rural area. It is tightly related with the natural environment. That is why we like to call this kind of villages, it's like street life. Whatever you ecosystem related to life and related to production. Yeah, in Chinese, it share the same term. 生 means life. Yeah, only we have good ecosystem, then we have life and we have like eco production. This is the definition of eco villages. Only in this condition, only in such village, eco village, there is sustainability. Like it's a way to prevent like external invasion, cultural.
So if it can prevent the outside pandemic, the epidemic, which is a more urban problem, preventing such kind of urban problems to go into the village, it can prevent such kind of epidemic effectively. So these two stories are the Chinese stories in 2003 and 2020, which was about a time span of 20 years. So why the COVID-19 pandemic has been spanning for 3 years, from 2020 to 2023, and why the 2003 pandemic, which is SARS, were stopped for only 1 year. Objectively, that's because China facing very fast urbanization in the past 20 years. In 2003, China only has more than 20% of the urbanization rate, less than 30%. However, in 2020, that number was 66%. And there are only 33% of the Chinese people are living in the village. So in the past, we are having about 70% of the people living in the village, but now we are only having 33%. So the living conditions and also the living culture combining the eco-villages and also the natural resources can effectively prevent the COVID-19 pandemic, while stopping such kind of pandemic in the cities will have a higher cost and also longer time. As we can see from the SARS and the COVID-19 pandemic, which was about only 1 year and 3 years respectively, and also lower mortality and higher mortality respectively. So the eco-villages have a significant role to play in the health sustainability. And we need to combine health and also sustainability, these two topics. And also, it is very important for us to discuss this topic as we just shaken off the COVID-19 pandemic. So this is my first story comparing SARS in 2003 and also the COVID-19 pandemic 20 years later, and also their real impact on society. And then let's talk about the second story. And these 2 days, the Dai Lihua professor from Peking University and also Professor Huang Ping from the Hong Kong University are just like me. We all went to the villages when we were young. And Professor Dai Jinghua said that he carried very heavy bags when he was 11 or 12 years old. And in the bag, it was medicines and also a treatment book. The treatment book is about 1.5 kilograms or 3 kilograms. So it was a very heavy book. I went to the village in 1968, and they went to the village in about 1970. And we hold the book, the Barefoot Doctor book, which means that the doctor did not wear shoes. So when I went to the village, we have the fellow teenagers of 10 million people, and they all hold the Barefoot Doctor book. And by that time, the villages are facing the severe problems of a lack of medicine and doctors. But during that time, they are not facing a significant problem such as poverty and also other kind of social problems due to the lack of medicine and doctors. And actually, the training of the Barefoot Doctor for only several days on how to clearly understand this book is very important. So that book, that manual, have pictures and also text. It can help us to identify those very simple and also easy diseases in the villages. In the traditional Chinese medicine, we have such kind of topic, which is to cure the uninhabited disease. And for example, when people face the pouring rain, we can have some kind of soup of ginger to prevent the disease. And it is a very different solution to cure the disease. So by that time, the healthcare problem is not a very simple problem in the specialized field. So the healthcare problem is more about to cure the unhappen disease, to prevent the disease from happening. And those prevention methods and prevention solutions are mainly from those teenagers who go to the village, who are only trained for the treatment. So when I went to the village, I was only 17 years old, and Professor Huang Ping, 15 years old, and Professor Dai Jinghua, 13 years old. And we are actually in the primary school or the middle school. And those teenagers can play a very great role in the healthcare sector in the village. By that time, we do not have such kind of modern systems such as social insurance and health insurance. But we are not facing such kind of severe social problems that were caused by the diseases. So how can we improve people's health? And how can we achieve health sustainability? And this is a problem that requires our attention and focus. So do we need to abandon all the experience in the past years? And can we have some reference from the past experience? And this is a very important problem and a very important topic. And we can also see that in the past years, we can see that the human resources were adequately mobilized. And some diseases that cannot be cured in the past. For example, the snail fever. And people are mobilized to treat the water to treat this disease. And this can help us to eliminate such kind of disease. So based on our past experience, actually we can solve these diseases. And this experience were barely mentioned in China, even less in the international community. And we also eliminate STD in the past, which were caused by the social reform. So it is very different from the Western experience, from the Western social insurance system. And in the past several years, we are actually facing more severe problems in the social health. So we need to take a new perspective on the cost that caused by the COVID-19 pandemic. And the COVID-19 pandemic is having a more significant impact on the whole world. And we need to
how many family are infected. We should really reflect on the past experience and find a new way to face all this issue. Like we were speaking with a few scholars from Peking University, a few of us as professors. We share similar experience. We are still young. We would like to share our experience or the stories to share with you all. It's not that it's not that we would like to do a debate, but I would like to share our experience with you all so that we can have a new perspective on the house care system. This is the first story I would like to tell. Like we were part of it, and I would like to share like a third stories when more of us when would like to borrow like the Western healthcare system to China. We've borrowed a lot of them, but we've ignored that a social foundation. But we need to really pay attention. The whole like all of the East Asian society. What do we call it? Like we are indigenous society. If we like to borrow thoroughly the Western system, like the Northern America, Southern America, and Australia, and most of the African continents. The indigenous society, the indigenous culture doesn't exist in the colonial region, but only in mainly in Asia. Yes, in the South Asia used to be a colonial region, but most of the East Asia, we didn't in the long term being colonized. Of course, there are some places. For example, in Vietnam, French were there, and then Philippines, and Spanish and American were there. And most of the Asian society, even during the colonial era, they didn't they wasn't like South America. Most of the indigenous, like in America, most of the indigenous population were like maybe just 2%. And like Australia, in this island, maybe the indigenous population is now below 2%. Yeah, but in Asia, most of the countries are still indigenous population dominated. Mostly above 90%. Yeah, the foreigners, the percentage of foreigners population is very low. And so Asia, especially East Asia, as an indigenous society, it has its own, it has its foundation. It has its foundation that is mainly a village background. No matter how industrialized they are or urbanized, like in Japan, it's a very modern and industrial society. Like an example in Asia, 90%, at least 90% urbanized. But what about its village? It is still like a foundation like before. Or the village, the main residents in this village, they are still farmers. And is the rural area are still like there existing. Even though right now in Japan, they still have like this it's kind of like a agriculture association, like, and also in Korea, North Korea and South of Korea, the settlement they own still in the form of a village, and of course the same as in China. The village is the form of lifestyles of residents. Yeah, so village is the basic units. We call it like village or community. Is still the basic unit of existence, of human existence. It is still like before the colonial history. It is like this as well. There is a free, and its mechanism is like, yeah, village community rationality. Village community rationality is foundation is the family rationality or household rationality. As long as the family rationality and the village related rationality is still there, are still there. Yeah, when we're talking about the influence of COVID on human society, and I can say that it tends to be if we keep the indigenous rationality and culture, it helps human being to cope with pandemic and also to maintain our health. Yeah, from this angle, we need to focus more on, pay more attention to a lifestyle or community sustainability based on the village units. Is the path to sustainability, is to help human beings to form the foundation or the condition of health and sustainability. And in many of the villages, we can rarely see like urban, like obesity, like only happen in cities. As long as the village keep the rationality, as I shared above, the people who live in villages, they maintain like the environment. Like a professor in Renmin University, he shared about like a system called one family, two management. Within the village or within a household, they not only need to guarantee the ecosystem, but also they need to guarantee the land resources, the health of the land. And the way, like the chemical way of pushing the production or is more like towards the city, it's more for the city or for the urban consumption. But like they only produce their own like provisions on a healthy land. Yeah, so that they are healthy, like they use organic method, ecological farming, but for the markets, for business, for exchange, they sell it for like people who live in the cities. So yeah, and then like what JOMO share, like obesities, the percentage of obesities is increasing. It is mainly in like very like colonial society. They use a lot of pesticides.
And for those highly industrialized countries, they do not have the village rationale. And they will face the hidden food insecurity and also the problems that would undermine the people's health. And such kind of problems were actually the living model that people are industrialized. And we need to focus that the eco development is to maintain the microbacterial diversity during the society development. And the human's health is based on the reasonable and also rational structure of bacteria within the people's body. And if people do not have enough microbacteria in their body, they are actually eating the food from the factories, which only have the necessary microelements, and they cannot intake very reasonable structures of microbacteria of the natural food. And in that case, people will have insufficient bacteria in their body. So we are facing more diseases that cannot be explained. And this are actually pushing the healthcare as an industry and generating more GDP. And this, in turn, promoting the healthcare as a very major industry. And this kind of vicious cycle mainly taking a toll on people's health. And I hope people from home and abroad can listen to our reflections on this kind of problem. And such kind of GDP is driven by the insufficient health. And this kind of GDP growth will not be conducive to the health of people or the development of future generations. And we need to think what we really want. So such kind of problem is a fundamental one. And now industrialization is causing a heavy overproduction, and the overproduction has already been causing the world war, the conflicts among human beings. And such a kind of conflicts would be transferred from the developed countries to the developing countries. And we are also using the industrialized method to change the agriculture development. So it actually promoted the social progress to some extent, which is causing a significant financial flows. And many multinationals entering into the futures market and also the agricultural market, making the agriculture industry as a highly industrialized and also highly financialized industry. And we think this is a symbol for modernization, but it will not be conducive to the sustainability. And it will also have a negative impact on the sustainability of the natural environment for our sustainable development. And unconsciously, we will take this kind of modernization as some kind of human culture that we would like to chase for. And this will cause such kind of, it will cause children to go without those sugar heavy food, and it will make them difficult to understand what is the most important and why the nature is important. And our eco-village is undermined by such kind of modernization, and our house is also being undermined. So in the current stage, we are seeing a new phenomena, at least in the mainland China. More and more people are seeing more problems in the modern hospitals and also the modern healthcare industries. And they find it more difficult to have their disease cured in the modern hospitals. And they're gradually going back to the tradition and also resorting to the traditional Chinese medicine. However, in the past half century, the TCM was actually modified by the Western medicine, and they're taking some kind of performance appraisal system, just like the Western system, and they are taking some modern diagnostic equipment and also methods of Western medicine. And traditional Chinese medicine are actually taking the traditional ways to adjust people's health and also to improve people's health and to gradually cure the disease. And such kind of method has been modified by the Western medicine, and it is very difficult for the TCM to gradually adjust the people's health. And I would like to talk about the last story. Now, many people, including me, going to the village to seek for the village doctors, because village doctors are not taking the performance systems as a Western medicine. And also the certificate for the village doctors are not complying with the certificate system of the Western doctors. And many village doctors have reserved the traditional holistic view to improve people's health. And such kind of treatment is the holistic coordination between the human body and also the natural conditions. And in recent days, I'm getting suggestions from the village doctors. And in many cities, we are holding some training courses of TCM courses, and it will gradually become a cultural courses to adjust our mindset, adjust our behaviors, and also combining some auxiliary functions of massage, acupunctures, and also many therapies. And different kind of methods are playing their role. And this kind of phenomena are actually similar to the Korean doctors and also the Japanese doctors. We can see in the whole Asian regions, we are seeing many traditional medicines. And it is very different from the Western medicine that is mainly for profits. And such kind of Western system is gradually abandoned by the Asian regions. And we will resort to the traditional medicines. And in recent days, I also resort to the Mongolia doctors and also the Tibetan doctors. Different traditional medicines forming different methods and solutions that are complying with their natural conditions, weather, etc. Such kind of medicine culture is developing.
So more and more people, they are coming back to the traditional culture. Yeah, lastly, I would like to share what I witnessed before in Hubei province. Local friends took me to a village doctor. Yeah, the road to the village is not quite convenient. The doctor of the village, his clinic is at his own, her own hometown or at her home. There are a lot of like cards from different regions, like with different regions, card plates. Yeah, a lot of like patients coming to visit this local doctor, and he or she doesn't charge that much. Yeah, it's very cheap to see this doctor. Yeah, I would like to share. This is the last story, and we are actually adjusting our perception and also our behavior and action. We can no longer give over our life and our next generation and our health to like those multi-international companies, and also this revenue-based healthcare system. So what we can do then, if we cannot give our life to those systems, how could we build a community sustainability? How can we build sustainability of indigenous society? We can build a sustainable life and sustainable health. This is what all of us need to think of. And I believe there are many friends maybe build like I'm overstating, but I would like to kind of give you a bigger contrast. Yeah, especially when we some people just don't like what I'm talking about, like multi-international company, revenue-based healthcare system. Yeah, so all the hospitals nowadays, they're trying to make money. They're trying to make more money. And in such systems, this kind of like system are very affected. So we just need to consider this kind of factors, systematic factors. I'm not talking about who is right or who is wrong, what is right or what is wrong. Just based on like this few stories I shared, I would like to like consider, I would like to include like this kind of thinking, the systematic thinking into my consideration. I know like some people like to criticize, and I welcome that. I just like to share with you such a reminder and some stories, and I hope that this kind of stories have its own significance. Thank you.
Thank you very much, Professor Wen. And he gave us very important and wonderful experience in China. And now I would like to invite Professor Anita Rampao. She is former Dean of the Faculty of Education, Delhi University in India. And Anita will give us some experience about the Indian People's Science Movement and how they deal with the health issue and also science education. Thank you very much, Professor Anita Rampao.
I would like to take this forward. I mean, I'm really happy to listen to Professor Wen and come after him. And I'd like to connect this with the challenges that we face. We have a people's science movement, and then we have a people's health campaign, very large movements which have been working for the last many years. And I would just like to say, link this with many other aspects of our work. So one, of course, like the last thing that I was hearing from Professor Wen was about, this thing about how do we look at traditional medicine? How do we see that the commercial lobbies and the commercial, producers are actually going to be against this? So it's not an easy fight, because, for instance, during Corona, we had so-called, and I'm saying so-called religious personalities, very, very well-known yoga personalities who are known all over the TV, but who also run big establishments of producing traditional medicines. Now, they came out with the chief of our, some of our doctors, and said that there is a medicine called Coronil, which will cure Corona. And they also dismissed sort of the allopathic procedures. So there is the medical association, our medical association actually went to court against this kind of a campaign, which was in a way dismissing the protocols of regular scientific procedures, which the doctors and our public health workers, because it's not just scientists, but it's public health workers, it's epidemiologists, it's the whole sort of network of people who can understand patterns of disease and work with what disease and what medicines. In our country, was quite active, even though the government had and the government organizations had taken some very ambiguous positions, but our doctors and people on the field were very active. And so they had to, at some point, even contest this kind of thing, because they were all, the politicians were saying that you can stand in your houses, and then millions of people were doing that. They were standing on their terrace and banging their plates and saying, "Go, Corona, go." So, you know, all this can get very, it can get very problematic, because you can evoke people's sense of nationalism, you can evoke their sense of community, evoke their past, the glorious past and the traditions, and actually then also mislead them. So this for us was a big campaign, especially during and after COVID. But I do accept that the scientific aspect of this, how do we empower, how do we engage, how do we educate, sort of not just the health workers and the village workers who become health activists, but also right from the beginning, from our school program. I mean, I work in education, and right from the beginning, we talk about what really is health, and also the system, the school textbook puts it on me, you know, it puts it on the child, that if you're ill, it's your fault, it's your family, you're not taking it right, you must do this correctly. So it moralizes it, and it puts it on the individual. Clean your teeth properly, drink boiled water, don't bother about what water you're getting, whether it's drinkable or not. So right from the early years, how do we engage, educate, and empower? And I think that is the challenge we face in this immensely diverse area and terrain in which we work. And also in the terrain where public health systems are not strong. So how do you bring that awareness, a kind of community watch, which can question its own public health system, I mean, we have court cases right now on a doctor who actually worked. His religion is important. He's a Muslim doctor, and he worked in a majoritarian area where he was actually supporting children. But the whole fact that there was not enough oxygen in the hospital has now come onto him, because he's been outspoken about the government system. So there are very, very difficult challenges and conflicts of interest within which this work is carried out. And so it's one, of course, is right to health. That's a major movement, and right to health workers, right of sanitation workers. During COVID, the most exposed were the sanitation workers. They were the only ones on the road. There was a devastating lockdown for almost 2 years when everything was closed, and people didn't get food. Migrants didn't get place to stay. They were walking back home. But our sanitation and our lowest rung of healthcare workers, the attendants, the nurses, they were exposed. They were they took the whole responsibility, and in an amazing fashion. I mean, I myself was in a hospital for 2 weeks, and I know what strength we got from these people who knew that they were exposing their own people at home, their families at home, but they were giving us the faith and the trust that we will overcome this disease. It was amazing. But these people don't have the equipment, they don't have the support, they don't have the kinds of facilities they need. So it's actually a fight for the sanitation workers, for the health workers. So along with this, what is important also, that it's a question of livelihood rights. It's a question of ecological justice, because the kind of work which people are doing, they are exposed. Can you believe it, that in our recently held national elections, there are almost 100, I mean, the count is not so clearly declared, but there's so many people who died of heat stroke on poll duty, just because they were duty officer, they were on polling duty, and they died of a heat stroke. Because why were these elections held at a time when the temperatures, even in Delhi, were 46 degrees, 45 degrees, without enough protection? So livelihood rights are related to their health and related to the conditions under which people are working. And who fights for them? That's the question. Who really ensures? Another issue that comes up is that the government has offered a very large, instead of offering public health support, the government is giving life insurance, health insurance. Now, who benefits from health insurance? These companies. These are all privatized. And the question is that you are forced to join certain digital platforms. Your privacy, your personal data, all your data is being mined, and that mined data is sold further by other third-party bodies. So this entire large body of people and this population which really needs health support and health care is pushed under the commercial, the sharks, the marketing sharks who want to get your data and get your money from the government for your insurance, but whether they really save you or protect you is another question. So a lot of these things, what happens in terms of digital mining, how we are pushed on, even during COVID, we were being pushed onto a platform, onto a digital platform, on even children. It was said that children should join this Setu, this platform to keep themselves safe from COVID. And we are very, very wary. We are very apprehensive because there's too much surveillance in any case. And these are used as further surveillance of people, not necessarily of helping them. And so the question of strengthening public health systems, and Margaret, how much time do I have?
No, you have 5 minutes.
Okay. Yeah. So the whole struggle against privatization, commercialization is huge. I'm not even getting into that. The pharmaceutical company and the patents to negotiate that in terms of research to develop COVID vaccines, we have done amazing work. And we have done it through the paradigm of knowledge commons, that how do we share knowledge across the world, across scientists, without getting into the patents. And this was amazingly done during COVID. I've never, as a scientist, I've never seen this happen before, as it happened during 2020. The protocols of dealing with the disease were known to us. The genome code was known. Everything was known, and COVID vaccines were being produced. So this is, again, a huge area, the area of knowledge commons and how you do research for public health and public good. And also the question of preventive health, preventive and community health. We have a whole department in one of our best universities which works on this, because unless you really monitor, understand disease patterns, unless you look at the diverse populations, you cannot just talk about medicines and talk about healthcare. And one of our states, Kerala, one of our states has been amazing because it has built over the last many years. It has really invested in public health and in monitoring, and right through, it's a smaller state and it's more urbanized in that sense. So the reach is easier, but it was the kind of analysis and monitoring that they did during COVID and have done it for the last 2 years. This was built over decades. So this is our model, one of our models, but the rest of our country is really in a challenged state. And I think I will leave it here that these are the kinds of issues, starting from the earliest notion and education about health, about community, about traditional medicines, about how we look at disease and we look at health, going right up to the time of looking at people's livelihoods, their rights in the conditions under which they're working. No one addresses those rights, even including manual scavenging. That is something which is under law, that you cannot, but humans go into the drains, and it's shocking. Even in our capital city, every year, we hear of 10s and 20s and 30 people dying because of the poisonous gas when they step into a drain just to clean the sewage system of Delhi. And these people are the lowest caste. So it's tied with caste. So it's a major struggle, but we really need a movement for that. And we need science and social activists along with the health experts to work in this. Thank you.
I would like to invite Kinchi to talk about the experience in Venezuela, particularly the communal or nothing movement. And Kinchi is the coordinator program on Cultures and of Sustainability Center for Cultural Research and Development, Lingnan University, and she is also the founding member of Global University. So Kinchi, please.
Thank you so much. Today, we welcome the Vice Minister from the Venezuela Commune to talk about the Venezuela introduction and experience. And because of the weather condition, the large typhoon, and he cannot come on site. And I would like to talk about the Venezuela experience based on my understanding. In 2008, Mr. Wen, Mr. Dai, and Mr. Huang and I attended the forum in Venezuela with about 100 academic leaders to have a deep understanding about the local difficulties and also the government experience and solutions, including education, medical care, etc. And we are very honored to have a face-to-face communication with Chavez's president. And by that time, we discovered that they have a large problem. They do not have the food sovereignty. So they are actually based on the single citizen economy, and which is mainly based on the oil production. However, the oil processing sovereignty is not within the Venezuela, and such kind of oil production caused a huge anger from the multinationals. So we can see many US pressure on the Venezuela's oil production. And so Venezuela hope to increase their sustainability and also the production of food. So we went to the local communities and we also encouraged the people to produce crops and by cleaning the waste in the land. And we also encourage those Cuban people to talk about their experience in Venezuela. So in 2008, we are actually facing the severe problems of their single economy.
So since 2010, we've done research on like a comparative studies of 7 countries. And in Venezuela, the head of the research team is now he's the vice president of Venezuela, focusing on the economy. And they said that they would like to change like the like simple economical situation resulted from the colonial era. And to 2020, at the beginning of the COVID pandemic, and Jade, Xiaohui, and also Zhixiong, and me, this group, a Chinese group of us, to Venezuela. We know that Venezuela is suffering from like the sanction of from the United States, and they organize a lot of mobilization, and the government bought some food for people. Some like maize powder, some staple food, and the community distributed like in a event to different community members. Yeah, but at that moment we felt like the mobilization of community mobilization was quite effective. And this year in April, we were invited again to observe what they were doing, like in general election. Yeah, they are not. It's not an election on presidents or like senators, but it's like a general election. So they mobilize different community members to propose like some to suggest what they would like to have in the community, from like 3 to 5 like suggestions, and then the whole community join together to select what they would like for their community, and they have like $10,000 to improve based on what they propose. So like $4.5 million in total. Yeah, so I can tell it's related. Remind me of the Kerala movement in India. Yeah, in the past, and it really surprised us because we have been following their movements. How do they improve their economy? Yeah, it is. Yeah, so yes, so we have also met the head of the research team on 9 countries. The comparative studies on 9 countries. We've so like 270 copies in China. So we can tell that the Chinese audience are very they really want to understand more of these comparative studies. And they told us that it's a good news because he's now the vice president on economy. So he showed us some data because we were very touched because we feel like food autonomy is very important. Food sovereignty is very important. And there's one photo, so one chart. In blue is like the percentage of their food food autonomy, and the red color chart is on like relying on imports. So 98% is they have 98% of food autonomy, including like butter, corn, and I feel like wow, their food autonomy is quite high. And they even reach like 85% of the vegetable sovereignty, and 70% is sugar and dairy, milk, and not enough. Maybe 35 autonomy is on oil, edible oil. Yeah, they have oil. They have they have oil, but not edible oil. And also there's tuna they imported. The tuna is not like stable food. Why do we like import like 30%? Because then they asked me they like to have tuna can. So it's kind of different diet. And from this chart, in like 20 years progress, they are very conscious to increase their food autonomy, on improve their production and also agriculture and production. And on 2020, when we visited them, I feel like in the past 3 years, most of the food they can rely on themselves rather than relying on import. So they really inspires us in such a difficult era. They can make it, and also yeah, especially in the sanction of United States. Yes, they have like a lot of the savings, overseas investments, and yeah, it's very difficult for Venezuela. Yeah, so a lot of the middle classes there, they cannot bear like the insecurity of basic provisions, and they migrated to other part of the world. But still, some of them they still stay there. And yeah, so through commune, and yeah, so they use the commune or nothing is very popular saying from Charles. Yeah, so it really shows us that when Charles promotes a commute, they use the Chinese pamphlet, and they translated the Chinese like a commute pamphlet into Spanish. So this time we went to observe how's that commute movement going. we realize the mobilization has done a good job. They have done a good job on mobilization, and relied on like this self-organized system. Yeah, so that but Venezuela, the most famous of it is the corn commune. Yeah, they have taken a deserted land and they planted corn and also raised some livestock. And during COVID, they supply like a lot of the food to the cities, to the urban region. And a few months ago, the leader of this corn commune, he was appointed. He was appointed like the minister of commune. Yeah, commune. Yeah, so we were feel like in Venezuela there are many, like, even though there's a lot of restriction and limitation, they're still under the sanctions of the United States. Even though under this pressure, they are kind of forced to walk on their own path. But very importantly, especially Travis, in his final life stages, he really said that commune or nothing. So in very important of mobilization, community mobilization, how did they, like all those women, they mobilize like people to come to join the election and to elect and also to kind of have their fingerprints. And I asked, why do you have to ask the fingerprints? And they said it's the first, they would like to, yeah, and they answer, yeah, only with the fingerprints, they know that who voted and who didn't, who had voted and who hasn't. Yeah. So I felt like there's a lot we can learn from this. And like in South Forum, from South and South, and the conversation between South and South, we respect each other, we learn from each other. Yeah, this is what I would like to say. And what Henan said, Henan said, apologize that he will find another time to speak to us. Yeah, and in South and Global University, we've done 2 series. Yeah, on the Venezuela's movement.
And we have many forums that have been put forward on the website for your reference. Thank you.
Thank you very much for Kinchi intervention and provide us some the experience from Venezuela communal movement. And now we'll have the Q&A sections. And as you know, we are doing live streaming, or not only in Zoom, but also on the Bilibili and Xiao'ertong, the social media platforms in mainland China. So our volunteers have collect some questions from the audience. So now I would like to ask Simon to read out the questions.
One other aspect of financialization of healthcare and the unwillingness to train new healthcare professionals is that healthcare workers are poached not only by the private sector, but also by other countries, particularly from the global north, from the south. What measures can global south countries take to counteract this? And the second thing is, you mentioned the problem of provider-induced demand in social healthcare insurance. We see this in the rise of C-section births, even when they're not needed, as well as oversubscription of medication. How would a revenue finance system, as you described it, address this issue? Can you just elaborate on what you mean by revenue finance system?
Please read out all the questions.
Oh, sorry. You mentioned an increase in food prices. Are these increases a problem of lack of food due to an increase in transportation costs or due to other factors? Both China and Russia have seen bumper harvests in recent years. What role do you see these countries playing for food sovereignty, food security, and improving access to nutritious food? And what, if anything, can be done to hasten that transition? And last, part of controlling one's diet is knowing what food is ingested. Do you see the rise of reliance on delivery services and fewer people having the time or ability to prepare their own food as a potential obstacle for a balanced diet?
Yeah, and we also have some questions written in Chinese. So Tianyu, please read out the questions in Chinese.
Professor has mentioned that the social housing insurance need to intake finance to take care of the expenditure. That is because we have higher medical cost. And in China, we have the illness prevention ideology. And we believe that other kind of countries have similar thoughts and can help to reduce the medical expenditure. And how can we integrate such kind of philosophy into the social housing insurance? And the second problem is that now Chinese people have the illness prevention, but we cannot identify some kind of information are accurate. And how can we to effectively transmit such kind of philosophy in the society, especially we are facing misinformation in the internet? Thank you.
Personally, I find it quite difficult in many societies to discourage emigration of healthcare personnel. For example, you now have schools, nursing schools in the United States, in the Philippines, which are dedicated to sending people, you train people to be sent abroad. There are also other places, for example, in Anglophone countries in Africa, such as Zambia and other countries in East Africa, where they are training a lot of nurses and doctors who subsequently emigrate. In a society to discriminate against them in particular, especially when in the case of the Philippines, they have borne the cost of their own training and education with the expectation of earning much more. It's very difficult to refuse to allow people like that to leave. So it's very important to create the conditions for service to basically induce people like that to remain within the country. There are many ways to do so, and I think one should also think of a number of incentives, not just material incentives, but also moral incentives. And this has proved quite successful in many societies. One of the countries with a great number of healthcare personnel is Cuba. Cuba has trained a lot of healthcare personnel, and many of them have served overseas. Now, undoubtedly, we cannot deny that a few have continued to stay overseas, sometimes refusing to go back. But the vast majority goes back to Cuba. So we need to begin to think about the kinds of incentives, because people are not driven by making money alone. And this, I think, is extremely important. The people who are driven by making money, whether they stay within the country or do not stay within the country, will have different types of consequences, which are very difficult to anticipate and to make very great generalizations about. The second question, which Simon read out, if I understand it correctly, was about unnecessary procedures. How do we discourage unnecessary procedures in a revenue-based system? Let me. I didn't have time to elaborate, but I think it's very important for us to recognize that once you have a revenue-based system, you can also change the incentives for healthcare. So healthcare providers right now are paid, whether in a market system or in insurance system, they are basically paid and remunerated according to the procedures which are conducted, necessary or unnecessary. And this is a major problem. And correctly, I think we all recognize that. However, you can also change incentives. For example, in a market system in the UK National Health Service, in the National Health Service, you have a so-called capitation system. So all doctors are paid according to the number of people under their care. Okay, the people involved in the NHS, they are paid up. So it is in the incentive then is to keep them in good health, keep them, incentivize them to keep the people under their care healthy, so that they do not need to come to seek health. And this involves a great deal of preventive health, and so on. So the incentives are very different when you have remuneration based on the people under your care, you know, and this is so you may have more people under your care in the urban areas where they can come to see you more easily. In rural areas, you may have less people, and all these things need to be adjusted under specific conditions, because it costs money for healthcare providers to go out to the countryside. It also costs money for people to come to seek healthcare. But you basically are changing the incentives. So you're changing the remuneration is linked to people who are in good health rather than people who need curative services. And this, I think, basically is fundamental for the success of preventive health. The third question was on the question of food price increases. Food prices may increase for many, many reasons. Historically, of course, even in non-market-based economies, when you have a poor harvest, or when you are not able, because of drought and so on, you are not able to get enough food produced, and food prices may increase in a market system. We also know that in non-market systems, societies often are organized differently, and sometimes it can be handled equitably, but there's no guarantee. You could also have situations where people who are older, or people who are of different caste, and so on and so forth, are left to be much more exposed to health-threatening conditions. So we cannot assume that just because you do not have a market system operating, that the outcome will necessarily be equitable. But the point really is that the food. When it comes to food, what we have in the case of Russia and Ukraine, when the war started in 2022. In fact, both Russia and Ukraine had the highest output as far as wheat was concerned, and so on. So why did food prices go up? Food prices went up because there was a lot of speculation, and the speculation was moved by the big speculators, because, as you all know, right now, incentives are. The main speculators are very, very big investment houses. And when you have that kind of a situation, you had the food prices going up, especially during the second quarter of 2022. But when it became clear that there was no real food shortage, prices came down. Okay, so you can have food prices going up because of speculation. You can have food prices going up because of real shortages. You can have food prices going up because of localized shortages, and as we all know, you know, and in many situations where it is not really a question of whether you have real shortages, but really the ability of poor people to secure that food, to buy the food, even if it's available on the markets. So you have a situation, for example, during the food crisis of 2008, where you have a situation where there was not where the food was available, but people simply could not afford it because of the contraction even in some of the rich countries in the West. So I think it is we cannot make generalizations. We have to look at particular situations and what causes prices to go up. The last point, sorry, I think that was those were the three questions, if I understand correctly. But Simon may correct me if I'm wrong. Thank you very much.
Thank you very much, Professor JOMO response. And I would like to invite Professor Wan, to respond some questions.
So very special, because before the reform, like if you have disease, you there are like social system that support that, and including education, healthcare. Yeah, the government really supports. And also in rural area, there was a collective healthcare, and senior people, and a lot of the barefoot doctor also supports rural area, even though it is not like a high a very advanced technique, but at least it is available in rural area. But right now it's totally different. And yes, but I haven't done much comparative studies in the global level. But after the 80s, more and more like the money are running out nationally, and that is why a lot of the previous healthcare or education system that are supported by the government are shrinking. And of course, on the other hand, there's the capitalists or the mechanism based on the market developing. So it is we couldn't guarantee the social healthcare system. So during this transition time, it is very tough. It was very tough until entering into 21st century. China started to what was developed in the West, the social care system, kind of to learn from the West. And from the 21st century, the first 10 years of 21st century, we started to develop like a social care system that partially the government carry, and partially carried by individuals. So we combined two accounts, and this system, it just lasts for like maybe dozens of years. And what we receive, but it's still a very tough system, especially for rural areas, especially after 2005. We kind of open, there's no test, zero test for like rural areas. So the local money is not enough to cover all the villages. So since 2006, the central government also covered the healthcare insurance for villagers, and the central government like carry like 80% of the healthcare, and then all the villagers, the farmers, they just have to carry like pay the 20% left. Maybe just around like 100 yuan in total. So both ends doesn't have to pay that much. But until now, everyone at least has to pay for like 300 to 400 yuan. Yeah, and of course, in proportionally, the central government also have to pay for the 80%. Yeah. But I saw a lot of the villagers, the farmers, they cannot afford such a expense. Yeah. So it is a very systematic questions to see how we can adjust adjust this system. It relates to like the medical expenditure increasing, and also other medical conditions or medical supply are moving towards the urban area. So maybe we can all do some research. Thank you.
No. Okay, thank you very much for all the speakers' presentation. And then we learned many experience from the Global South, including Malaysia, India, Venezuela, and China. I would like to point out two things that we still have to focus more, and particularly about the land system and also the traditional medicines in the Global South. So we hope our research team and also the forthcoming sections and also the research will continue to tackle these two problems. One is about the land system and also the traditional medicine in the Global South. So thank you very much.